I would like to welcome our esteemed audience for the first pediatric session today. With me here, we have Dr. Ajay Vincent, who's our visiting faculty from Canada, and we are blessed with the presence of Dr. Arif. And I would like to call on stage Dr. Osama Hakim, who needs no introduction. He is consultant in Maghrabi and stationed in Dubai. I would like to request him to start his presentation on the true or pseudo strabismus. I hope everybody is getting settled, and he can start in the next maybe 10 seconds as everybody gets settled.
Good morning, everyone. Thank you so much for being with me today. Usually when I'm presenting something, I try to record what I'm doing in the clinic, so you can see everything exactly what I'm doing in the clinic. When we're examining a patient in our clinic, any child coming to our clinic, we have a big problem. We don't know what is the diagnosis. Is it strabismus or not strabismus? This is the first question. This is a very important question. We don't have such technology which is available in other branches which help us. And this is unfortunate. This is the true fact. But we have to deal with it. We don't have such technology which can tell us. If that's a child, I don't know if he has squint or no squint. This is the first and the most important question, because if this patient doesn't have squint and you diagnose him as has squint, this is a big problem because you will go for surgery and management. So what we do, if we see a patient like this patient, we can see she looks like having esotropia. So what do I have to do for this patient? Does I have to go for the surgery? Does I have to do cover uncover? Does I have to do motility check? This is the first question. When the patient comes to my clinic, I said, this patient has esotropia, I have to do the surgery. But the first thing you have to do, and what we are talking about today, is you have to do cover test, cover uncover or alternate cover test. This is the only point which I wanted to get it from my talk today. It is the most important, valuable point you have to learn today. So I start to making cover uncover for this patient. I do cover uncover, alternate cover, whatever, covering test, whatever you put it, cover uncover, alternate cover, and keep doing it. Don't fed up. Take your time, keep doing it, hardly. If there is no movement, there is no squint. If there is movement, there is a squint. This is the golden rule in the strabismus, the golden rule. When anyone coming to my clinic and is staying with me, I tell him, just learn cover uncover, alternate cover. This is what we have now, and then you learn it about 50% of the strabismus. The other 50 is easy. But this is the most tough part. You have to learn how to do cover uncover. Take your time. If you look at the refraction of this child, we find their high myopia, and with high myopia, we have what we call negative angle kappa, and this is the reason for she having pseudo-esotropia. Pseudo-esotropia. So the diagnosis is mainly pseudo-esotropia. So cover uncover is the first step you have to do. First step, and the most important step you have to do the patient is to do him cover test. Let's go to the other patients, and through the patient you get the fact. You have to know. This is another patient. When I look to her, I can see this is a reflection of the cornea. She looks like she's having exotropia. So the first impression, even for me, after all of these years, I say she has exotropia, and I have to manage with exotropia. So I ask myself, she's ortho, exo, or I don't know. So what do you think in your mind? I don't know. For sure, I don't know. Because you didn't do cover uncover. You have to do cover uncover, alternate cover test, and then you have the proper diagnosis. Don't to be misled by anything else. And during the coming 5 minutes, we will see many patients. All of them were misleading for me, and I have hundreds of them. All of them misleading for me even. But without cover uncover, alternate, without covering test, I cannot tell the most important question, does this patient have squint or not? So I'm doing cover uncover, alternate cover, no movement. So simply pseudo-exotropia. Don't try to explain why she's exotropia. You don't need to go a negative angle kappa, positive angle kappa. She is pseudo. Whatever you will tell it is apparent. She is pseudo. Don't do anything. She is pseudo-exotropia. She has no squint. So, and this is very important because I have patients in my clinic coming from other doctors. They referred for me because they have squint, as they don't have squint. Another patient, you can look to his eye. He looks like he has esotropia. We are trying to do him cover uncover, alternate cover. No movement. This is due to the wide intercanthal, the depressed nasal nose and the wide intercanthal nose, but there is no movement. There is no movement. And I take my time. I go it through it slowly. I do it, I repeat it. Maybe I take 5 minutes because I want to find the squint. It all has is pseudo-esotropia. So I do this test. The first step, the most important step, Take your time, do it by your finger, by cover test, by a paper, by whatever you will do it, but keep trying with the patient until you find a movement. And after finding the movement, you can tell from this movement what is the type of strabismus, and then we can move to the last step, what is the amount of the deviation. So another patient we can see here, she looks like she has esotropia, so she's iso or exo or apparent, but when you examine her, you will find some movement here. So she's coming from in to out. She is moving from in to out. So the first look, she looks like pseudoesotropia, but she's not pseudoesotropia. She actually has esotropia with pseudoesotropia because she has the breast nasal nose. So she did surgery, and after surgery, you can tell her family that she looks like she still has some squint. So the diagnosis here is very important. She has esotropia. So you have to manage her, but you can tell she is ESO because you see it like that. Another patient, I just saw him maybe 2 weeks ago, and he looks like has outer deviation, but he's a pseudo. And another patient, his eyes looks inside, but there is no movement again. We keep doing all our best, but no movement, almost no movement with the glasses, even the glasses in his eye, no movement. So we cannot tell there is any deviation, no deviation. So pseudoesotropia. So you saw in all cases what I'm doing, the first important patient. Look to this patient, which until now I cannot diagnose him. 100% he has exotropia in this eye. This is the reflection in the center. This reflection is inner. His exotropia, 100%. 100%. No doubt in this patient. I never doubt this patient. This patient is 20/20, has a good stereo. He's not eccentric fixation. He's not abnormal correspondence. He's nothing. Everything is perfect in his eye. But cover and cover tell me there is no deviation. So, no squint. Whatever you see in your mind is not important. But in the fact, without cover and cover, you can do nothing. For this patient, I said, I keep examining him maybe half an hour. Half an hour. I'm trying to find anything to explain to me why this reflection looks like this one. I don't have an examination, maybe something is a sclera, maybe whatever, but cover and cover, alternate cover is the golden rule, which we have to strictly adhere to it, whatever we see. This is the most important thing you learn today. Any patient coming to your clinic, please, take your time doing cover and cover, to cover test for him before saying he has strabismus, and then after that we can manage. So we say cover testing is the gold standard objective method. It is an objective, unfortunately, for determining the presence, type, and the amount of misalignment. This is what we have till now in our field. Thank you so much.
Thanks, Dr. Osama. May I ask you something? Where are you going? That was a nice presentation, thanks. I was wondering, when you have a child and you diagnose pseudoesotropia, a very young child.
Pseudoesotropia.
Pseudoesotropia.
Yeah.
Do you tell them it's pseudoesotropia, you don't need to come back? What's your recommendation?
Yes, this is a really good question, because sometimes we diagnose our patients, they are pseudo, exo or ESO even. But usually we get him back again after 3 months. Because even when we diagnose them as a pseudo, sometimes we are mistaken, diagnose them as pseudo. So we have to re-examine them again. We don't send them go forever. We bring them again back after 3 months to examine him. Maybe another 3 times after 3 months, maybe after 1 year. I keep examining them because sometimes I diagnose them as pseudo, but after a while I discover there was some deviation which I couldn't detect at this time, and it will be showing up by the time. But usually I have to check them. Yeah, this is important.
Yeah, particularly the younger children. Sometimes they were pseudo, and then they do develop a true strabismus. I've had that happen a few times.
Yeah.
So I think it's important that these patients, when they're young, under 4, they have to continue to be followed.
You have to get them back again. Yeah, sure. Because it is very clear that he's pseudo. It is very clear that he has deviation. But even I did the cover test, and the cover test tell me there is no deviation, but still there is doubt. There is still doubt because we don't have a subjective method. Everything depends on me. It is objective. So we have to give him back again 1 time after 3 months, maybe after 3 months, maybe after 1 year. Keep following him because sometimes it is shown up, as Dr. Khan mentioned. Yes, thank you so much.
Thank you so much.
Thank you so much.
Now I'd like to ask Dr. Hyatt to come up. Dr. Hyatt Khan, he's consultant ophthalmologist and assistant professor at Mohammed bin Rashid University Medical Sciences Center, and he's at Mediclinic Parkview Hospital here in Dubai. Dr. Hyatt.
Thank you so much. So, very important topic. I'll be sharing some important information. So, right off the bat, we are in a pandemic. We are out of one pandemic, but we have a bigger pandemic. And by 2050, we are expecting half of the world population wearing minus glasses. Out of them, if you see 10% of the world population may be under the category of high myopia and associated complications. So quickly, I'll go very fast because I have a lot of things to share with you. This study talks about how excessively that you see there is an increase. If you notice there is an increase in the myopia incidence, especially after 2019, where things did change for children. And this is right across different age groups. And if you notice, not only the mean spherical equivalent has exponentially dropped, if you notice there, more, of course, if you notice there, especially girls, they are having more reading habits maybe. That is why we see that happening. But there is an increase. There is definite increase in low myopes. That means new people are coming in this category. And most of the data that you see, this is a large group of patients, and it's statistically significant. So we have a real problem here. So we're looking at the increased use of smartphones, iPads, children bringing the phones very close. All of that has contributed. Of course, if you see this, the smartphone penetration has increased dramatically. So coming on, how do we manage these patients? So that is what I'm going to discuss. So I'm quickly going into a couple of studies. The Blink study, I'm not going in details, but they're basically concentrating using contact lens with an add of 2.5 for near, and that actually helps the kids in defocusing in the periphery, and that has come up with good results over the last 3 years. There are a lot of other different contact lenses now which we are having, and they are helpful. We're having peripheral gradient contact lenses. We have bifocal, which I just talked about, and then we have the EDOF contact lenses, which more or less have the same principles as EDOF IOLs that a lot of us are knowing about. And if I may just put it together, starting with the pharmacological, which is, I would say, the most important, which I'm going to discuss more in detail later, we're talking about atropine eye drops in low concentration. And of course, there are other new, more selective drops that are there, but there's still a long way to go in terms of research to establish their use. In terms of opticals, of course, spectacles, and then going, well, under correction of myopia, we thought it may help, but not a very robust. So I would say that we dropped that idea. Progressive add lenses in spectacles have helpful effect. There is a very important study on Canadian Chinese in which they use a base in prism with executive bifocal, which has found to have a very promising results. And then defocus incorporated multiple DIMS technology also is very promising in terms of spectacles, and it's available now. In terms of contact lenses, the RGB lenses, the soft bifocal dual focus lenses, also very promising, about 25 to 30% decrease in the rate of increase. And then, of course, the extended depth of focus contact lenses, about 32% decrease on an average. And lastly, of course, orthokeratology, which we are doing in Mediclinic. We have started this, and we have a very good results, especially these lenses, which have been very fruitful because kids have to wear it overnight, and in the morning they take off, and they're good. The only constraint is that above -5, they don't work so well. Of course, behavioral changes are important and environmental changes. Increasing the outdoor activity has a direct effect, especially in daylight, which has a very promising result. Of course, decreasing the screen time, the rule of 20, every 20 minutes, take a break of 20 seconds, all of that has helped. And then, of course, surgical. Of course, I'm not getting in there, but anisometropic cases, LASIK, PRK, ICLs, those are for cases which are resistant to any kind of treatment, and we are really desperate to help those kids. And of course, lastly, a combination of all of this. So in my own humble practice, I use atropine, and if I still see the problem existing, I add orthokeratology, and it can work very well and have a synergistic effect. Going in, undercorrection, of course, was not so helpful in improving, but of course, multifocal spectacles and bifocals have a helpful effect in controlling. And then, of course, ortho-K lenses that you see is just a good paper which talks about comparison of how well these treatments are effective. So, again, the same thing, I'm not going in detail, and effectiveness of atropine, this is very important. Different concentrations available. Some of the pharmacies are compounding, some of them are ready-made. 0.01% is freely available. Not so much in UAE, but there are several places we are getting it from India, and we are using for patients. And what we found is 0.01% up to 0.05% is...
The limits of the conventional treatment, either it will not correct the stereopsis, and also eccentric fixation is difficult to treat. The recent modalities of amblyopia management depends on binocular vision therapy, virtual reality games, dioptic games, and biofeedback fixation training for eccentric fixation, and also the levodopa-carbidopa combination is a good pharmacological treatment. Binocular vision therapy depends on giving each eye different targets, either by filters or by virtual reality games. The virtual reality games now is a game changer, as it can use both eyes and give each eye different image and can control even the patching by either darkening or complete patching. Also, it gives us a good variety of tools for young children in order to avoid some sort of lack of compliance. It is very capable, as we can do with it almost everything, either patching or even can correct some sort of strabismic element. Also, these virtual reality games come to the computer with a lot of applications on it. Also, there is a home-based therapy so that the patient can do the treatment either office-based or also home-based. Eccentric fixation can be now treated with virtual reality games, and also there is some sort of a new technology, the Maya, which is macular integrity assessment. It is a machine that can tell the patient which part of the retina is the best area to use. Usually this machine is used for age-related macular degeneration, but in amblyopia cases, it gives us a better tool to give the patient where is the best area to use. The limit still for the virtual reality games is the organic causes like macular scar or optic atrophy, and also nystagmus. The take-home message, there is no age limit for amblyopia therapy, and try binocular methods if regular treatment fails. Thank you.
Thank you. So anybody has any questions from the audience, please go ahead. I'll just give you the mic quickly.
So thank you for the presentations. Actually, my question is about the atropine for the myopia.
Can we save the question till the end then, because it's.
Yes, sir.
We have 15 minutes at the end if we stay on time, so we want the questions, but we also don't want to fall behind.
Dr. Ihab is one of our consultants in Mediclinic, Airport Road, Abu Dhabi. Please go ahead with your presentation. Thank you.
Hello. I'm going to talk about surgical treatment of sixth nerve palsy. So the sixth nerve palsy is the commonest isolated cranial nerve palsy. The sixth nerve is supplying the lateral rectus muscle, and the affection of the sixth nerve palsy is causing a limitation of abduction. The clinical characteristic of sixth nerve palsy is patients are suffering from the horizontal diplopia, which is increasing in the field of the action of the affected muscles. Yeah? There is an esotropia, there is a limitation of abduction, and the patient adopt abnormal head postures to compensate for the diplopia. and adopt the position opposite to the affected muscle. So we have to go and do ophthalmic examination and orthoptic evaluation. Ophthalmic examination to exclude the presence of a papilledema, which can be a cause of the disease. The common etiology of the sixth nerve palsy is trauma, especially road traffic accident, macrovascular lesions, diabetes, and causes of increase of intracranial pressure. So the orthoptic evaluation is mainly to do determination of the angle of deviation as well as the power of motility of the lateral rectus muscles and the other extraocular muscles. So it is very important for the treatment to differentiate between paresis and paralysis, where the paresis there is abduction possibility and the eye can move passing the midline. Paralysis, there is no movement passing the midline. As a differential diagnosis in adult, you have thyroid myopathy and you have orbital myasthenia gravis, as well as myositis due to orbital pseudotumor, and as well as any isotropic deviation with diplopia. In children, the most common causes of, as a differential diagnosis, is Duane retraction syndrome and late onset esotropia with diplopia. It's very important to do neurological examination as well as radiological and laboratory investigation to find out the cause of sixth nerve palsy affection. There is a spontaneous recovery. It depends on the cause. In isolated cases, 70% of the cases can be recovered spontaneously within 6 months. Recurrence is possible. The non-surgical treatment is easy. It's just patching one eye, but avoid patching one eye in cases of children, as you can get occlusion and amblyopia. So you have to do covering both eyes. You can use prismatic glasses if the angle of deviation is small. You can use as well Fresnel add-on prisms on the glasses if the angle of deviation is big. The botulinum toxin injection can be used to improve the condition temporarily, and it can be used as well as adjunctive to the surgery. It can maintain the diplopia-free zone in the primary position. The only backdraw of the botulinum toxins is the occurrence of ptosis or vertical deviation, but fortunately it is not high. It represents about 5% of the cases alone. So you cannot go ahead and do surgery before passing at least 6 months after the discovery of the sixth nerve palsy. The aim is to correction of the esodeviation, to improve the abduction, and to develop a central diplopia-free zone without adoption of any abnormal head posture. If you have a paretic eye, then you can do a surgery according to the function of the lateral rectus muscles, the degree of deviation, and the concomitants. If there is action of the lateral rectus muscles, then you have 3 types of surgeries. Small angle deviation, you can do 1 muscle surgery. If the angle deviation is bigger, you can do 2 muscle surgery. And if the large angle deviation, you can use 3 horizontal muscle surgery. This gentleman has a macrovascular lesion. He has a left sixth nerve palsy. So after 6 months with treatment with prismatic glasses, he's still having left head tilt, even he is wearing the prismatic glasses. I have done for him only a lateral rectus tucking, and the left picture shows the affection of the operation. There is no abnormal head posture, and there is no diplopia in the primary position. This is a condition pre-operatively where he has abduction deficiency. Still, the eye can pass the midline. This gentleman had a car accident, and he was in coma for about 2 weeks. And post-operatively, post-accident, he developed right sixth nerve palsy. In the left picture, you can see the abduction deficiency of the right eye. And this is a picture as well showing abnormal head posture in the form of head tilt to the right due to diplopia. I have done only medial rectus recession as well as lateral rectus tucking.
Can we 30 seconds. Summarize, please? Time is.
Oh, sorry. Yeah. And this is both. So for the complete paralysis, we have to do transposition surgery of the superior and inferior recti muscles. Yeah. Sorry, I have to go back for this. This lady has bilateral 6 and 7 nerve palsy. I have done transposition surgery for the superior and inferior recti muscles. Yeah. And this is a pre-operative pictures. Post-operative pictures, there is no diplopia in the primary position. Yeah? And the last picture is this young lady. She had a surgery as a child as if she's infantile esotropia. And I have discovered that there is abnormal head posture. And I have done partial superior and inferior rectus transposition of the superior and inferior recti muscles with posterior augmentation sutures. And this is an improvement of the abnormal head posture after surgery.
Thank you.
And now this is the 6 months post-operatively. There is no limitation of elevation or depression after the surgery. Thank you.
Thank you. Thank you so much, Dr. Babli. Wonderful presentation. Like always, huh? Now I'd like to invite Dr. Ajay Vincent, our guest speaker from Canada. He is working at Hospital for Sick Children in the position of Director of the Electrophysiology Services there. All yours.
Thank you for the opportunity. Boy, I'm on a time crunch, so let's get going. So I have no disclosures. So today I'll be trying to go over some of the symptomatology that can help you differentiate between a genetic diagnosis and non-genetic diagnosis. So briefly, as you can see, it could be because of a condition that requires intervention, like say retinoblastoma, glaucoma, cataract, or sometimes it could be a complex genetic disorder or a developmental disorder which has diagnostic significance for the patient. So the aim should be to identify the common presentation and signs. To make matters a bit complicated, sometimes there are non-genetic causes that also share overlapping symptoms. So the idea would be to diagnose and promptly refer to the pediatric ophthalmologist or to the eye geneticist. So when to refer one? If a child has poor visual behavior with wandering eye movements in a baby or a young child, it can be due to a multitude of causes. Causes which are non-genetic have placed it in italics. So it can be due to cataracts, developmental eye defects, or inherited retinal dystrophies, the commonest being Leber congenital amaurosis. So examine and make sure of any details of the visual behavior, altered red reflex, family history of similar inherited retinal dystrophy.
99% of the time, when you see the phenotype that I'm describing, that's what we're dealing with. So because of time, I'll end there, and maybe we can talk about some of the other causes at another time. Thank you.
Thank you, Dr. Khan. That's a great lecture. For the sake of audience, I think you alluded to in a bit that ERGs need not be normal despite it being macular dystrophy. Now, in your experience, what range of patients, or in your cohort, what range of patients have a normal ERG or someone showing cone dystrophy versus cone rod dystrophy?
Well, when the children present at 6 or 7 years old, which we see here in the region because there is a double mutant allele that's a founder mutation. It's cone rod dystrophy.
Wow. So it's very severe phenotype.
Yeah,
up in
because
the
when they're presenting that young. But when you see the typical Stargardt patient who's presenting maybe in his 20s, with just a maculopathy and the vision is not that decreased, very often the ERG is normal. But here I'm talking about children. So I'm talking about under 10, these patients tend to be very severe. And again, there is a founder double mutant allele, homozygous in the population that's responsible for the majority of those severe cases.
Thank you, Dr.
I also agree with Dr. Arif. Even in Dubai, we found a couple of them quite aggressive ABCA4 patients. And genetically, we did the testing and we found them to be positive.
But the classic ABCA4 phenotype is milder, as you're suggesting. Yeah. It's typically, the ERG is often normal, and it's adult onset, and it's just involving the macula. If a disease only involves the macula, the ERG will be normal because the ERG is a global measure of retinal function, and the macula is a relatively small portion of the retina.
Dr. Arif, just 2 minutes, I would like you to just summarize about the RP65 treatments, what is going on, what is the latest? You've been doing it, so just a 2 minutes take to our audience.
I don't want to take too much time, but RPE65-related retinal dystrophy is as Dr. Ajoy just had mentioned in his talk, is the condition for which there is gene therapy. We have gene therapy for it. We offered at Cleveland Clinic Abu Dhabi. We've treated 6 patients, 12 eyes. They're doing well, and I'm actually speaking about it tomorrow. So anybody who wants to know more about that can come tomorrow.
Great. Thank you so much, Dr. Arif. And now I would like to call upon, once again, Dr. Ajoy Vincent. He would be talking about electrophysiology testing in pediatric genetic disorders, the power of precision, precise phenotyping, right? And this will be a little longer talk as he is our, you can say, keynote speaker. So please go ahead.
Thank you again for the opportunity. I think Dr. Khan actually set the stage perfectly for this talk, telling you that it's very important that you do genetic testing and genetic diagnosis because sometimes you can see masquerades, which looks like this, but it is not this. So on that note, I have 4 cases. Depending on time, I want to at least share 3 cases with you, and we'll conclude. And at the end of this talk, hopefully I can convince you all that doing electrodiagnosis is not a waste of all of your time. So I have no relevant disclosure. So case 1, this is an 11-year-old male with European ancestry who had complaints of night blindness when he was a child. There is no other family history. His best corrected vision is 20/25 in each eye. He has a red-green color defect in either eye. And these are the fundus pictures and OCTs. If you look carefully, the fundus is largely unremarkable except for some discrete white dots, deep retinal dots, along the superotemporal arcade. When you do OCT within the macula looks to be normal lamination, but temporal and superior, you can see that the middle and inner retina is totally disorganized, and you can see these rounded iso and hyperreflective structures which look like whorls in the temporal and superotemporal retina. So we did autofluorescence. On autofluorescence, you see that there is like a sectorial hypoautofluorescence along these regions, and there are small specks of hyperautofluorescence in the rest of the peripheral retina. So we did ERG because this did not look typical, although we'll come to that in a moment. So the bottom panel is the control ERG. So this is the dark adapted ERGs, the first 3, and the last 3 are cone ERGs. So to a dim flash, there was no positive deflection or there was no B wave. So it signified rod photoreceptor or bipolar cell dysfunction. When we did the standard flash, which is the dark adapted 3.0, and bright flash, which is dark adapted 10.0, there was an A and a B wave, just like in control. But if you see carefully, the timing of the A and B wave is delayed, And secondly, if you look at the ascending limb of the B wave, here you see small wavelets which are oscillatory potentials which are missing. Now, when you go to the light-adapted ERG, the flicker ERG, here you can see sawtooth-like robust responses, whereas in this top panel, you see very reduced, markedly reduced and delayed response to the flicker ERG. And now when you look at the slow flash photopic ERGs here, you can see that again there is an A and B wave. A wave is probably normal, but the B wave is reduced. And again, you see a smooth aspect to the ascending limb of the B wave. More importantly, you see that these cone responses here and these rod responses here have similar morphology. But if you look at the controls, they are vastly different. So 4 points here, that not detectable rod response, simplified standard and bright flash ERG, which looks similar to the cone response, and the flicker ERG amplitude, in fact, being very small to the point that it is smaller than the A wave of the single flash ERG. So this ERG picture is diagnostic for enhanced S-cone syndrome. So why is this ERG picture? It's because in normal retina, there is about 120 million rods and 6 million cones, and majority being LNM cones. Whereas in enhanced S-cone syndrome retina, most of the rods are de-differentiated into S-cones. So basically, this is a S-cone dominant retina, and all the responses that you're seeing on the ERG is from the S-cone. So it is very slow because S-cones can't react as fast as LNM cones. And as you know, typically enhanced S-cone syndrome has nummular pigment clumps, and as you saw from the fundus picture, there was no clumps to be seen. So we did genetic testing through the clinic, and most common gene is NR2E3 and NRL. And the standard genetic testing, we cover all the exons in the lab. And we are supposed to see 2 mutations in either NR2E3 or NRL. We only were able to find 1 mutation in NR2E3. There was no other variants found. Because the ERG was so characteristic, and because the phenotype is so tight, we said, okay, let's do whole genome sequencing. So we did whole genome sequencing, and alas, there is a variant hidden in the intronic region, which is in the deep intron. So normally when you do genetic testing, the classical teaching is most mutations are in the exons or in the boundaries of exons and introns. Deep intron was probably treated as junk, but that is no longer the case. There are some variants which are within the deep intron, which can actually create a new exon and cause an aberrant expressing or aberrant protein. So this was a prediction from a software which said that, if you have this mutation here, it can cause aberrant splicing and an aberrant exon. So we moved to validate it functionally. So to make a long story short, so this is, if there was no mutation, you would have a band which is about this size. And this is from a mini gene assay. With the mutation, you see that the band length is different, and when we sequence that band, it contains this aberrant exon. So it leads to an aberrant protein. So this is where an ERG is diagnostic, because you can actually pinpoint it. It pinpointed us to the diagnosis. Now let's go to case 2. Now we are in the zone. This will be easier, I promise. So this is a 13-year-old proband born to consanguineous parents of Sudanese origin. He had exotropia, surgically corrected at 10 years. Nyctalopia noted at 11 years. Best corrected vision is 20/70 and 20/40 in the right and left eyes. Contrast sensitivity is almost normal. And if you look at the fundus, other than for myopic changes, otherwise it looked unremarkable, as was the OCT. And here again, this is the ERG. As you can see here, the first 3 are dark adapted ERGs, and the other 3 are light adapted. When you see in the dark adapted ERG, the most striking feature is that there is an A wave, which is from the photoreceptors, and the B wave here is very small compared to the control. It tells you that this is selective rod bipolar cell dysfunction. And if you look at the light-adapted ERGs, again, I want your attention here. If you look at this trough of the A wave, it is a lot broader than what you see in control. In control, the A wave is immediately followed by the positive deflection of the B wave, whereas here, there is a trough. And that signifies cone on bipolar cell defect. So here you have a patient who have nyctalopia, who have normal-looking fundus, and selective on bipolar cell defect. So the most likely diagnosis is congenital stationary night blindness. The storyline is same. We did genetic testing looking at all the exons. Everything came back to be negative. And then we decided to do whole genome sequencing, where we looked at deep introns and non-coding regions of the gene. And to our surprise, we found another deep intronic variant in a gene which is already known to cause congenital stationary night blindness, GPR179. Again, the story is the same. This variant is known to cause or is predicted to cause aberrant splicing and a cryptic exon, which we then subsequently validated in patient-derived cell line and mini-gene. Again, if you see here, this is what you would normally expect. In the patient line, it is at a different size, meaning that there is inclusion of this exon. Case 3, and this will be the last case. This is a 6-month-old infant who presented with status epilepticus. Upon admission, the child was noted to have bradycardia. Milestones were delayed. Mom noticed nystagmus at 3 months of age, but this mom actually revealed to us after the fact. On examination, the child does not blink to light. And these are the fundus pictures. It is largely normal, maybe perhaps a suspicion of temporal dyspallor, but on the OCT, the retinal nerve fiber layer looked intact on bioptigen. And here is the ERGs. So again, to the dim flash, there is no recordable response. To the standard and bright flash, there is an A wave, but the A wave is much smaller than the control, saying that there is some rod photoreceptor defect. The B wave is smaller than the A wave, telling us that, there is rod bipolar cell dysfunction. And in the cone ERGs, both A and B waves are very reduced. In the setting of a normal-looking fundus, this is highly unusual, or ERG morphology. So we were thinking there is something else going on. So we did an extended protocol ERG. So this is a busy slide, but we will take it slowly. Extended protocol ERG is an ERG where you do a series of intensities and then try to figure out or try to dissect where exactly the problem lies. So this is a dark adapted ERG to a dim flash. This is the patient and this is the control. There is no B wave. Means there is a problem in rod bipolar cell function. When you do the standard ERG, again there is no B wave. So the conclusion is the same. So what happens when you do a standard flash ERG? What you're seeing here, this is your control and this is your patient. So when you normally do ERGs, you do a series of flashes. The characteristic is that every flash should be reproducible. Here, something funny is happening. What you see is that with every subsequent flash, the A wave is getting smaller and smaller. And that is when the interval between the flashes is 10 seconds. When you increase the interstimulus interval to 20 seconds or 60 seconds, what is happening is that then the A wave normalizes. And that is the same when you see a dark adapted 10.0. Here you see again, this is the first flash, second flash, third flash. So it progressively reduces. When you have an interstimulus interval of 60 seconds, your A wave normalizes. So this part is characteristic for rod phototransduction recovery defect, or we call it bradyopsia as a genetic disorder. But something else is happening on top. So when you look at 60 seconds, your A wave or your rod photoreceptor contribution is normal, but your B wave here is still abnormal. It is still lower than baseline. So that means that this is like a dual retinal signaling defect. That is, it's coexisting. There is rod phototransduction recovery defect, as well as rod on bipolar cell signaling defect. And this was very unusual. So the clinical genetics department at the hospital did whole exome sequencing, meaning they looked at all the genes, all the protein coding areas. And the child also had epilepsy, bradycardia, and other associated findings. Now, when the results came, I was like so overjoyed to see that the phenotype actually fits. So there was a stop mutation in a gene called GNB5. Now, why is that interesting? There are two forms of GNB5 in the body. One is called GNB5 long, which is GNB5L, and one is called GNB5 short, otherwise called GNB5S. Now, in the retina, GNB5 long is expressed in the photoreceptors and can explain the bradyopsia part, and GNB5 short is expressed in the bipolar cells of the retina and can explain the on-bipolar signaling defect. So this was pretty informative. So I wouldn't go into case 4. The theme is the same. It is just to see how electrophysiology can help with the diagnosis. So I just want to end with the summary. I hope I was able to convince you to some degree that these cases highlight the need of ERG or electrodiagnostic procedures in establishing clinical diagnosis, in deciphering genotype-phenotype correlation, and in fact, it can help interpret genetic test results because sometimes genetic test results comes inconclusive. And to add, you should also keep in mind that not only exons or exon-intron boundaries are important, non-coding variants are also play a role in causing genetic eye disease. Thank you so much.
Thank you, Dr. Ajoy. It was wonderful, and this was a difficult. I was expecting audience to be sleeping, but everybody is attentive, and you made a topic which is a little dry, very juicy, very informative, and I'm hopeful our audience did get it. I will open the questions, please. If our audience have any questions, please go ahead. If we can have some more mics, if there's a possibility, or else I'll just give the mic. Do we have more mics?
I'd say.
Maybe I would like to invite even Dr. Osama and others speakers to join if there are, please, so that, questions can be asked.
It's a question to Dr. Ajay, especially the last is, how reliable is the ERG in children and how easy is to do it?
So basically, there are different ERG modalities you can use in children. So if it's a very small child, you can probably use a skin electrode ERG to start with. And once the child is over 6 or 7 years of age, you can do a standard ERG. Again, there are nitty-gritties as in the type of electrodes you use. So you use like thread-like electrodes, which are very easy to insert to the eye, and patient cooperation and trying to do it in the nick of time. Kids you can only get for a certain amount of time and they lose attention or they start crying. The other thing is, the rule of thumb is if the child is not so finicky when the drops are being put, that is a good indicator that you can get useful information. The other thing which we always try to do is, if when you do ERGs, every time it should be reproducible. So if you do 2 flashes for a response, it should be identical. If it is not identical, means that's not a reliable test, so we have to repeat the test. So always look for reliability, reproducibility, and try to do it as fast as you can.
Can I just make one comment about that? Everything you said is absolutely true, but I'd like to just stress that ERG is not like taking a fundus photo. You really have to have a dedicated center. You have to be doing it regularly. It's not something to do once every 6 months or something like this. So I don't think that ERGs should be done by everyone. I think, there has to be a dedication. Someone has to be very trained to do it properly. A lot can go wrong, so.
Thank you.
That was a point that is absolutely important. So make sure there is a full-time person and a staff who can interpret, because it may not be everybody's cup of cake. So it is very important that you have a trained person and a person with interest. That is a great point, Dr. Khan.
Just a quick question. We'll take with short questions. Please go ahead.
Yeah. Thank you, everybody. It was a wonderful session. So I have two quick questions for the myopia treatment. First of all, do you find it easy using contact lenses for the children? From my little experience, it has been, it's not very easy. Those children usually go to school, they may lose it. In this environment in the Gulf, it's usually dusty, it's hot. I don't know about you with this experience. This is question number one. Question number two, at which is the minimum age you can use atropine? I mean, okay, it's written in the atom 6 to 12. But for example, if you have a 2-year-old with -8, absolutely, or you have a 16-year-old with -10, for example, would you use it?
Very good questions. Both of them are clinically so relevant. Let's go for the first question. Contact lens usage is very challenging. And are you talking about ortho K lenses or are you talking about journal?
No,
I think you're talking about journal.
Yeah.
Definitely, even with adults, even with myself, I find it challenging. So that challenge is always there. How you can mitigate it is you can have an in-clinic, your optometrist, where you can actually give the best possible counseling and explain the parents. So in spite of everything, sometimes it doesn't work. Now coming to the ortho K lenses, I found in especially any time above 10 years, it has a personality thing also. You have to see the personality of the child, the family, how well they are to take that treatment and how devoted they are really to control. So their motivation factor is extremely important, right, to embark on that. But I have had really good results and patients have done pretty well. So I have been using the ortho K lenses and we are doing pretty well. Now going on to the second question, there is no clear answer as I do understand, and I will keep it to, of course, there's a whole group I would like to, I don't think there is a clear age. Sometimes parents come and you'll see a child, you started with the -2 and then 6 months it is -4 and the child is just 3 years old. And it's extremely disheartening for us. What options do we have? And I do tell them about that, yes, you have something that you can have, atropine. Very important to mention here is the concentration. These cases, I would strongly suggest, I don't have a scientific basis, but definitely a higher concentration of atropine, not 0.01, maybe 0.05 will be the best choice. If you have a setup where you can compound it, that's the best way to go about. But I will give it to my colleagues if anybody would like to give their opinions of younger age group using atropine drops.
Yeah, this is a very important point, and I'm glad you brought it up. You know, the atropine has been is used to treat the so-called school myopia or environmental myopia. And when you have very young children, like 2 years old, who come in with a -8, that's a completely different disease. So personally, I wouldn't use it, and I would be concerned that the patient might have a retinal dystrophy or a vitreoretinopathy. Even congenital stationary night blindness, which was mentioned, you know, the fundus can look normal. The vision can be pretty good. It can be 20/30, even with the glasses. But they are -8 at 2 years old. And, you know, atropine is not going to do anything for them. So if there's a very young child, under 3, who has very high myopia, we really should be looking for secondary cause. And I would say those atropine studies don't apply to that population.
What would be your best management when it comes to like CSNB patient who has a very fast progressing myopia? What options? Because parents are really desperate and they would like to know whatever they can. What would you?
Well, you're right. You start with the higher, you know, 0.05. And combination, you know, now we have the the contact lenses and the DIMS lenses. So as you were saying, it depends really on how motivated the family is. You know, that's a large factor in this. There are some families now who are very educated, a lot of Asians actually, South Asians, Koreans, and who come in and they're very educated, and both of them are myopic and they've done a lot of reading on the internet, and they come in and asking for this multimodal treatment. Whereas other patients, you know, won't even buy their children glasses. So it really depends on the family dynamics.
I feel that sometimes it's a collective decision. We are living in an age I don't make sole decisions. I put the options across the table. I give them the risk, I give them the benefits, and then I take a collective decision. And I think a lot of parents will go either way. And that is the challenging part. So there is no clear answer, but of course, as rightly pointed out, there you go. So we need to thoroughly investigate these kids for dystrophies. Any other questions, or if anybody would like to make any comments? We have time, of course.
I would just like to highlight some of the points that Dr. Ajay made. You know, they were great points, and I wish we had more time to discuss all of them. But a few of them really, I think, are very relevant for the UAE population. One of them is that these children with nystagmus, I've seen so many children with nystagmus who are otherwise healthy, who've gone and seen neurologists and had MRIs. When you have a child who's otherwise healthy with nystagmus, most often it's ocular only, and that should be evaluated by a qualified pediatric ophthalmologist or an ocular geneticist, not by a neurologist. The neurologist is just going to have an MRI for the patient, and if it's isolated, if it's only nystagmus and the child is otherwise healthy and the disc is not pale, you know, it's very unlikely to be neurological and should be first seen by a pediatric ophthalmologist or an ocular geneticist. The other thing that you mentioned, which I really want to highlight, out of all of the reasons to refer to the ocular geneticist, one of them I think is very important, is when a patient, even with their visual correction, is not 20/20. We see that a lot. A child has, again, -8 refraction. With the glasses, they're 20/30. It's attributed to amblyopia. The retina looks normal, the OCT is normal, the fundus is normal, multimodal imaging is normal, but they actually have congenital stationary night blindness, and the only way you can diagnose that is with an ERG. There's no other way to diagnose it. So even if a child has just a high refractive error can be an epiphenomenon of retinal dystrophy. So any child who has a very high refractive error, whether it's hyperopia or myopia, at a young age should be suspected of having a retinal dysfunction, even if the retina looks normal. And the only way to understand whether or not it is a retinal dysfunction is by doing an ERG. So I think that was a very important point. And the third thing from what you said, it was in your last presentation, we talk about genetic testing, but there are some conditions that you can only diagnose by ERG. And it doesn't matter what the genetic testing shows. Like the enhanced S-cone syndrome. You can do whole exome sequencing in a patient, and you might not know what you're dealing with, you might not get anything, but you do the ERG, and if it's pathognomonic for the enhanced S-cone syndrome, you know that's the diagnosis, full stop, no matter what the blood shows. So there are certain things that can only be diagnosed by ERG. So if everyone some patients need an ERG. It's not like an extra thing, it's not ancillary, it's essential for some diagnoses. And I'd say the major one in the region is congenital stationary night blindness. We see a lot of undiagnosed congenital stationary night blindness because it's attributed to amblyopia from high myopia. And the only way to diagnose that condition is with ERG. Again, it doesn't matter what the genetic testing says if the ERG is showing that it's congenital. So I thought those were very important points for the region.
Question which I thought from the family, what's next after the diagnosis? I send it to the ERG, I get the diagnosis. So what's the next?
Well, this is genetic counseling for the family. They're dealing with a hereditary condition, and this has implications for the family. Sometimes they want genetic counseling. They want to know the risk. You can avoid it in future pregnancies. The other thing is, there's research that's going on all the time, and there might be something that's relevant to the patient's particular mutation, it might not be happening now, but it might happen tomorrow. And if you don't know that if the patient doesn't have the diagnosis, they'll never benefit from any research or trials or anything like that. I'll just ask you one question from your presentation, if we have time. I don't know if we're out of time.
We don't have anything. I think it's okay as long as the audience...
I'll just ask one quick question. You know, you showed a patient who had pseudo-esotropia and true esotropia. Yeah. So what is your target angle in that patient?
Yeah, for sure. It is, as we mentioned before, as a cover, alternate cover is our key point. So we're measuring the deviation by what we have, and then we correct what we have only by the cover and cover. What we are measuring.
You're not going to make them exotropic?
Never do that. We have many patients coming to our clinic. Actually, this is I have many patients who has apparent exo or apparent ESO, and they ask me to correct this shape, but we cannot do anything for this one. Actually, we have some patient coming. I have many adult patients who look exo, and they're telling me, I have many people looking at me, and they tell me I have a deviation. I do cover and cover. For me, at the beginning, I diagnose them, they have exotropia, but after cover and cover, alternate cover, or covering testing, they are pseudo-exotropia, and we can do anything for them. We have no cosmetic. We cannot touch their eyes. They have diplopia, and you converted their life from cosmetic to diplopia patient who will come fight and claim you. So we can do anything. So many times we have patients who have deviation, but they don't have true deviation, then don't touch them. This is the key point. Yes.
Sometimes after surgery, the patients have pseudo.
Oh, this is what mentioned. Yes. Yeah.
So I think we have covered a good session, and I'm thankful to all our audience. They have been really patient. Is there any other question, or we can just close the session now? Thank you so much for being a part. We have a tomorrow session in the morning. I hope to see you all. Thank you so much, and hope to see you tomorrow. If we can have a picture, all of us. Thank you.
You were there also?
Yes. Today I was working in
First time. I was expecting it another 15 minutes. Professor always